I'll let the legal expert comment on that.
Sure. Can you hear me?
Yes.
So I just wanted to respond to that obviously when you have institutions and laws being implemented and institutions working, it makes a big difference. When people feel that they have recourse in the law. And to that end, I mean, there are laws protecting patients, there are laws protecting doctors when you're out in the field from this kind of violence. There isn't a special regime, but doctors are protected in many ways. One, for example, you go and report to your administration. And if you want to pursue legal recourse, the Pakistan Penal Code, I mean, all the sections are applicable to doctors as well. There's sexual harassment laws. And that, is an institution that seems to be working. I'm sure you have a committee here as well. Yeah, I mean, there are pros and cons. I think that's a long debate. But I think that the more we use these institutions, these mechanisms that have been created, and also to that effect, the new law now that we have, fingers crossed, it should pass. It's been signed. It just has to be gazetted now. That there is now, as a result of the HCID work, there is now a law in Sindh for the right of way of ambulances, Rasta Do law. And not only does it define obstructions, it also makes it a duty, right? I think that we are a very altruistic nation. We don't believe in systems and education, institutions. Sorry, we do believe in education. That if we see an injured person on the road, the first thing we'll do is not call an ambulance. We'll try to help them, which is harmful. And that is acceptable in rural areas where there isn't an ambulance service. But in Karachi, I mean, your first recourse should be call an ambulance, call ED, call Aman, rather than handling the patient yourself. So that also kind of has finagled its way into this new law. So sorry, long answer. Thank you.
Can we open up for the questions to the audience now?
If no more questions, then, or maybe other questions may come up in the meantime, what I wanted to talk about was that when International Committee of Red Cross approached us, they said, let's do something for healthcare providers. But then they said, we don't work in non-conflict areas. Sindh, Karachi, Pakistan technically is a non-conflict zone. But hats off to, I think, I need to really appreciate the efforts that ICRC put in, because, and I being in education and research, I said, I don't want to do anything that does not have a baseline data. I don't know what I'm doing. I need to know what I'm doing, how I'm going to do it, how am I going to assess it, to know whether my intervention that I'm going to develop is going to be effective or not. So with that, I think a lot of things that came out of this was are surprises. I think first question that was asked for me was, when we were doing this research, what struck you? I said, I had never in my life, and this is actually true, imagine that somebody like a healthcare provider would come up to me and say, I really don't know how to deal with violence. I really don't know when somebody abuses me what to do. The other thing that struck me was, and this was by many people, because we couldn't present whole data, there are like, at this point in time, over 6 papers have been published out of this project, because we've been working since at the beginning, actually the beginning of 2014, so almost like 4+ years that we've been working on this project. The other thing that really surprised me was that educated doctors, postgraduates with good experience would say, it's okay for people to be abusive. As long as my tooth is not broken, it's okay, because they're worried, their patient is unwell. So, like internally, they did not believe that there should be no violence policy. There should be absolutely no violence. Like if you are providing healthcare, that does not mean that people have the right to abuse you, be it physical, and there were a lot of things. We didn't talk about harassment. People said that we harassed, and of course money business, kidnappings, and if you don't treat my patient, I am going to see you when you go outside of this hospital. And that's rampant, and like if some of you are interested, you'd probably like to look up the International Committee of Red Cross website. And of course, you can also Google and also PubMed because those papers are published. And you will know that all these findings are published, and some of you might be able to relate to it as well. I think I'll leave it at that. I think there's some questions coming up.
I would like to have a question. Hello, can you hear me? I would like to introduce myself first, if you allow me. I'm Dr. Javeria. I'm not a doctor, not an MBBS. I'm a PhD in healthcare architecture, and I've done my architecture from Indus Valley School. It was very fortunate for me to be part of the team, and it was very surprising that how such a broad spectrum and such multi-layered information was binded together, and how much effort was put in for all the data collection, and how it was finally converted. It took a lot of time and a lot of professionals to do that. So it is like a comment that I really appreciate and encourage such activities, and a lot of research came out of it. I personally wrote 3 papers out of the data we collected together under the umbrella of ICRC. So my comment basically, or my question would be like, how is it possible that such research could also be further taken, and more of such research could be possible where other institutions and other professionals could be overlapped, and multidisciplinary approach could be applied for more research, which is applicable.
I think we have taken it forward. If you see some partners, I know nothing about the penal code, whatever, yeah. So we work together. Doctors really are not psychologists, knew nothing about psychology. So Dr. Kausar, when she wanted to, we approached her and she agreed to work on the project, she said, I don't know psychology, which I was surprised to learn. I thought she would know. Having said that, right now the same study with some modifications is presently being done nationwide. So except Balochistan, because we didn't get permission to go into Balochistan. KPK, the capital authority, Islamabad, Rawalpindi, Punjab, and it's being done in not just urban areas, urban plus rural areas, same methodology. And before going into that study, before developing the questionnaires, we had done another qualitative study in the rural areas to develop the questionnaire. So everything that we are doing is scientific and on the basis of research to develop those questions. So that study is presently undergoing and it's going on. Yeah.
Thank you.
I think it's very important to identify what triggers this. Violence, bad behavior of attendants and the patients, and I think a significant period of time, what we find in our clinical practice, that communication skills, interpersonal skills, patience. Generally डॉक्टर्स के पास पेशेंस ही नहीं होता, वो सुनते नहीं है बात को. मरीजों के पास. So I think मरीजों के पास भी नहीं होता. But doctors के पास पेशेंस की बहुत need. I think we need to look at what are the triggering factors, and we need to do something on that. Workshops for communication skills and other things, particularly communication skills. I have seen a lot. Maybe Rizwan and Sadaf and everybody would agree with that.
So just because of 40% PG&E, so I hope you can hear me. Okay, thank you. So my first question is to Dr. Kausar. You said you were doing workshops for year 3 students and year 5 students and thinking of a refresher, but I think the need is more for the postgraduate trainees who are there in the field, facing the situation day in and day out. So why are you not considering
No.
I know you're doing something.
शुरू क्यों नहीं वहाँ से किया?
शुरू वहीं से किया था. शुरू वहीं से किया था.
I'm sure you can respond. I'm sure you've done something. Just a question I raised. My other question is to Dr. You were looking at the interventions that you have done, and first of your intervention was, as far as I can remember,
studying the effectiveness of training.
Yeah, so you said that the resources ही नहीं है, and you said the doctors are too few. There is no limitation on the number of working hours, the number of patients a doctor is supposed to see, and I can relate this to people working in the public hospitals, especially in the emergency units. there may be too many patients, and there may be limited number of doctors. So how can we help these poor people? Nobody is training them, and you don't know much for them. So please.
So I'll respond to your first question. When we developed the manual, the training that we started, the first training was started with residents and house officers at Jinnah Hospital. So, and then the other manual that was for emergency medical services, so ambulance drivers, all ambulance like ED and Aman Foundation. So, and they were in hundreds. The numbers, we did present all those numbers because most of it is published. So that's kind of there. And Shiraz, do you want to respond to your safety? Yeah.
All right, so I mean, all our recommendations are based on the evidence that we generate. One of the recommendation was that a doctor should give a minimum time of 8 minutes to every patient. Okay, so if you have an OPD of 3 hours, you should not be seeing more than 20-24 patients a day. So based on the turnover of your patients every day, you can estimate the number of doctors that you need to have in your hospital. And if you have this number, you can simply recruit enough resources to be responsive to what is needed in the hospital. So all this appears simple, but again, who has to do it? I mean, this question keeps on coming and we just lose our track and we do not have any answer. Who does this? We have taken this project to Secretary Health, we have taken this project to Minister of Health, we have shared these frameworks with them, we have shared these reports with them. They promise and then they get changed after 6 months.
Then they get changed.
So, I mean, this is a constant struggle that we need to keep on doing. Ultimately, if you're calling a hospital, a public sector hospital, that has to be owned by government. If you're calling it a private sector hospital, not for profit, not for business, then you have, as an administrator, have to take the responsibility. We invite hospital administrators, we take it to government, and we keep on advocating this. Now, if somebody does not respond,
so far?
What?
Any success so far?
Well, marginal success, yes. We were able to introduce a few policies in JPMC emergency. You can see it is much better than what it was 2 or 3 years ago. But again, progress has to be said, it is not satisfactory. We are currently doing a national survey on violence against healthcare. And we want to take it to all the hospitals across all the province and share this message with them. This is what we can do. This is our job. Reacting to it is the job of the person who is responsible for doing that.
And also those who are affected, they need to raise a voice.
Yes, exactly.
Okay.
I hope somebody from YTA is also here.
We have one question.
Yeah, Dr.
Tashkeen wants to ask.
Dr.
Tashkeen Ahmed from surgery at Ahmed. From the Pakistani penal code perspective, what authority does the security guard who has been placed there to protect the healthcare workers at the time somebody from the family becomes rowdy have in terms of physically restraining them? What I have been told is that the security guard is not allowed to touch the perpetrator. They can only shield the victim, the medical team, or they can escort the medical team out, but they can't touch the perpetrator. That doesn't seem to me to be an effective way to protect somebody.
I'm sure the hospital itself will have trained the guard, and if they haven't, then general laws should apply. And if somebody is being unruly and they have been given the responsibility, then they can use what is reasonable force. Reasonable force may mean to prevent somebody from harming property or person, to stop them, and that may mean physically touching them.
Yes.
Unfortunately, that is something as a society we will have to accept, that is the prerogative of the hospital, and through them, the guard, who is their employee. Hopefully the guards are not outsourced. So it comes down to answer your question, what is reasonable force?
Proportionality laws apply.
Right. I mean, if somebody is physically harming you, you have a right to self-defense as well. The guard has a personal, outside of his or her status as an employee, they have a personal right to self-defend themselves as well. So I think all within the ambit of proportionality and reasonableness.
One question over there.
Dr. Sadar.
Myself, Mohammad Larif Khan. I am a third-year student from the Israel University. My focusing point and my question is about on the security system. अगर जैसा कि आप देखेंगे हमारे इंटीरियर सिस्टम में इंटीरियर सिंध में और बलूचिस्तान में हमारा जो सिक्योरिटी सिस्टम है वो टोटली अनएजुकेटेड है, क्योंकि जो हमारे सिक्योरिटी गार्ड्स हैं वही तकरीबन किसी वडेरे के मतलब रखे हुए होते हैं, टोटली अनएजुकेटेड है। और जैसे कि JPM से सर ने बात की, मैंने तकरीबन रमज़ान शरीफ में 15 डेज की इंटर्नशिप की थी, तो उसमें भी मैंने इमरजेंसी वार्ड में सिक्योरिटी सिस्टम से लड़ते हुए तकरीबन 5 से 6 केसेस देखे। तो इस चीज़ को हम कैसे बेहतर करें?
Security of the patient, security guards of the patient.
If it's a security guard of the institution, उनसे लड़ लिया।
I think some of the answers, the easy answer is restricting the number of attendants with a patient. That's the easy answer, and that's what's been tried as an implementation strategy at JPMC. But you're right, it does not work always. Because again, you know, like if it's a party worker, if it's a government official who can, you know, change you, move you in a public sector system, then they come with 10 people. And then media. Let's not forget the media. Media people also, when they come in, that's what happens. But of course, when we were talking to the media people said when we asked them about information, the doctors do not give complete and accurate information. You ask the doctor why you don't give the accurate, because like we've been working on this project for almost 4.5 years. Why you don't give this information? They say if we give this information, they are going to pick out those statements out of context where they can actually, it's not my disclaimer, nothing to do, it's just the research finding. So they would say that they're going to take something out of context and say that this doctor was not competent to deal with the patient. So healthcare providers are scared of the media, and media does not trust what the information is given to them. So there's a long way, like Dr. Shiraz said, it's a long way. And the onus of preventing violence against their healthcare providers is on the hospital administration.
Go ahead.
So I just wanted to add that we have, excellent study, and it's very broad-based, looks at a wide swath of hospitals. One of the things I think that we have to remember at the core as healthcare professional educationists and people who train these people to go out into the world is that the patient is always the primary concern, and that communication and counseling skills have to be perfect. We found, and we here at AKU, we are in a relatively very protected area where there's one attendant, where everything is hunky-dory, but really not. What we found out is we realized that in the middle of the night, when there were huge life-death decisions to be made, the residents did not have the skill set to have those difficult